Hello and welcome back everybody to actually our very last in-class, sort of in-class lecture for this particular course, General Psychology. I know some of you might still have some section videos to watch, so you might not quite be at the finish line after today's class, but this is, in terms of the lectures that I'm going to be presenting, the last set of material that we're going to be covering. And what we're going to be doing in today's class is really continuing the discussion that we had in our previous class about specific disorders that people could potentially be diagnosed with if they start to display behavioral or mental symptoms that qualify as kind of getting past the threshold of some of the different disorders that diagnostics specialists have designed over the years. What we were talking about at the end of our last class was this umbrella group of disorders that we call mood disorders. And in particular, what we did was lay out what mood disorders were in general, how they related primarily to negative, unpleasant mood. There is going to be an exception to that we're going to be discussing today in a really interesting mood disorder called bipolar disorder. But most of them do deal primarily with negative, unpleasant moods. And what we focused on in that class when discussing mood disorders was the very prominent disorder of depression. Well, what we'll be doing in the first part of today's class is examining some other types of mood disorders that are out there so you can have a better sense of some of the other things that people might struggle with if they do have issues regarding mood. One of the mood disorders that I like to talk about immediately after discussing depression is one that on the surface actually looks almost identical to depression. It's a disorder called seasonal affective disorder, and the name kind of gives away one of the key elements to this specific disorder. It tends to be very closely tied to the changes of seasons and, more importantly, to areas where the changes in seasons have a robust effect on not only exposure to sunlight, but kind of the daily routines of individuals. This particular disorder is really tough to pinpoint as to how many people in, say, the United States or other places struggle with it because it is very region specific. There are studies that have shown that only about 1% of people in the warmer climates in the United States, like Florida and California, can get diagnosed with this at some point in their life, where around 10% of people in Minnesota, Wisconsin, some of the northern states get diagnosed with this at some point in their life, and there's estimates that many people might actually be getting past thresholds but being undiagnosed in those places. And if you go even further north to places like Alaska, you can see a huge number of individuals struggling with symptoms related to this disorder. It might not quite get past the threshold of being a diagnosable disorder for some individuals, but this particular issue is very abundant in areas where there are those dramatic shifts in the temperatures and the environment. And when people are struggling with seasonal affective disorder symptoms in the cold months where they're not getting much sunlight, their symptoms are almost identical to those of depression. They've got the affect issues, the lethargy issues, the cognitive issues, and essentially, these experiences that these people are struggling with are really hard to separate from depression. The catch is that there is a big difference to this disorder from depression because this is cyclical. When people get to summer months, their moods actually tend to change. In fact, most people who struggle with seasonal affective disorder tend to feel really, really good during the summer. Definitely not to a state that we're going to talk about later called a manic state with respect to bipolar disorder, but most people with seasonal affective disorder really do not display any symptoms linked to depression during the summer. And that's a big tell to clinicians that they're looking at something that, even though the symptoms might be similar to depression, is indeed unique and has different things linked to it. Another thing that really separates out seasonal affective disorder from depression is that there is a specific type of therapy that's been established as a very effective way of helping people with some of the symptoms that they struggle with during the winter months. It's something called light exposure therapy, where individuals will spend a number of hours in a room with a very specialized UV light and just kind of be in the presence of the light while doing things. This light might not seem like the most amazing idea ever, but it's proven to actually be an extremely effective tool at helping people combat some of the worst portions of this winter season that they struggle with. And in fact, it's something that's been incorporated into a number of schools and other areas that realize that this is a real problem for students and people who are maybe susceptible to struggling from this particular disorder. This is also like therapy, but the kind of similarity between another mood disorder and depression is also the case for a disorder that's now called persistent depressive disorder. Historically, if you're looking in old books, was called dysthymia, but the name that was kind of given to it recently in the most updated version of the DSM really highlights what this particular disorder is all about. It's again relating to depression, just like seasonal affective disorder was, but there's subtle nuances to it that make it really different. There are rough estimates that around 2.5% of the population struggles with this particular type of mood disorder, but those estimates have definitely been challenged by a lot of individuals. There's some people that believe this might be an extremely undiagnosed thing, and others that argue that it's really tough to tease apart this particular disorder from depression because, like we talked about earlier, the symptoms of PDD or persistent depressive disorder are very similar to depression. If we're looking for subtle differences, it's usually that the symptoms tend to be a little bit less severe for individuals that struggle with this. But what tends to happen for individuals when they're diagnosed with this is that they've had these kind of milder symptoms of depression for an extremely long period of time in comparison to what typically happens for people who struggle with symptoms of depression and kind of get defined as having that disorder. For PDD, most clinicians won't even define somebody as struggling with this until they've had these depressive-like symptoms for at least 2 years. You can diagnose children and adolescents a little bit earlier than you can diagnose adults, but there's a caution really to diagnose somebody with this because it's kind of an indicator that these people are struggling with depressive symptoms that will not abate anytime soon. And this particular issue is kind of concerning for a lot of clinicians because it makes treatment a little bit more challenging, and it does tend to kind of get people lost in the cracks and really impact their lives. It's tough to compare mood disorders to each other and argue which one's better and which one's easier to kind of overcome. But when we're looking at persistent depressive disorder, what we do see is something that can really eat away at people's lives in kind of unanticipated ways. Usually, when people see milder symptoms, they think, oh, this one can't be quite as bad. But the fact that these mild symptoms last a really long time means that there's probably a large number of individuals that don't try to treat themselves and don't even recognize that they have a mental health issue. And because of that, it can eat away at their social lives, it can eat away at their work lives, it can eat away at a large number of different things that really are the essence of our everyday being. And because of that, it's again considered not quite as robust in terms of symptoms as depression, but just as detrimental. And there's a big push to really try to help people identify when they're struggling with this, because unfortunately, a lot of people might just be chalked up as kind of a grumpy person when in reality they're struggling with an actual disorder that could potentially be treated through a lot of the techniques that we talked about with depression before. The last mood disorder that we're going to be talking about is really a unique one. It's still put under the umbrella of mood disorders because negative mood is a very common thing that people with this disorder struggle with. But if we're looking at the thing that really makes bipolar disorder unique, sometimes it's called manic depressive disorder, it's the thing that's the first part of that other name for this, these things that we call manic symptoms. When people are struggling with bipolar disorder, they need to experience, to get this diagnosis, some sort of manic episodes. These manic symptoms can vary dramatically from person to person. Sometimes it can just be kind of a scatterbrained behavior for a short period of time. Other times it can be really impulsive, uninhibited behaviors. Sometimes it can be really angry and aggressive behaviors. But essentially, for somebody to be qualified as being diagnosed with bipolar disorder, these manic episodes have to be there. However, what comes with those manic episodes and the magnitude of those manic episodes do vary dramatically from case to case, which is why when clinicians start looking to diagnose somebody with bipolar disorder, they also tend to like to type it, try to kind of figure out which grouping a person's combination of symptoms actually best fits into. So if somebody's having a manic episode, what we call it sometimes a full-blown manic episode, but isn't displaying maybe depression, or maybe is kind of just fluctuating between a few manic episodes and kind of typical behavior, we tend to, well, clinicians tend to define this as bipolar type 1 disorder. When there's severe depression involved and only milder manic episodes, what's called hypomania, a person usually gets qualified or defined as type 2 bipolar disorder. And if somebody's just fluctuating between milder symptoms of depression and milder symptoms of mania, they're defined usually as cyclothymic. And these types of definitions aren't necessarily treated as distinct categories where each one is completely different from the other. It's just more of a means, again, for clinicians to be able to communicate with each other about what symptoms, what struggles a particular person is challenged with. And if you combine all these different types of bipolar disorder together, you see that about 1% of the population is diagnosed with this at some point in their life. And if they are diagnosed with this at some point in their life, unfortunately, this is kind of a lifelong thing. If we're looking for things that are usually linked to it, there are a large number of studies that suggest that there are some genetic factors at play with the development of bipolar disorder. It's a pretty darn heritable disorder. So if you've got family members that have been diagnosed with it in the past, your chances are exponentially higher to be diagnosed with this, to essentially manifest symptoms of this at some point in your life. And for people who struggle with this, again, since this is usually considered kind of a lifelong thing, what really is important here is kind of treating the symptoms and making sure that somebody can kind of stabilize themselves. Then in terms of some of the best stabilizers out there, it sort of depends on the types of symptoms that people are struggling with. Many people nowadays take what are called mood stabilizers, which kind of try to address both the depressive moods and the agitated moods. But for a long period of time, what people were being given were two different sets of drugs that were supposed to be taken when different symptoms were manifesting themselves. And this was really problematic when these were the common drugs that were prescribed, because many people who went through the depressive bouts didn't have the energy or the kind of mindset to take their medications. And when they were going through the agitated, excited, manic episodes, they often kind of felt like there was nothing wrong with them, that was just kind of the world around them, and they didn't really recognize their symptoms were problematic until long after they'd kind of gotten through the manic phase that can sometimes last, upwards of days or weeks when it happens to individuals struggling with this particular disorder. So these new drugs called mood stabilizers were really pushed on the market, and they are very effective, but it's still sometimes for this particular drug combination a real challenge to get people to stay on their drugs when they're going through different phases and when they're in kind of the extremes of this particular disorder. For milder symptoms of bipolar disorder, I know I don't have it listed here, but I should probably mention it. There are some therapies that can sort of help. There's some research suggesting that cognitive behavioral therapy is somewhat effective. But for this particular disorder, since it is a very persistent, lifelong thing, drug interventions have really championed the kind of load when it comes to what most people pursue and most people are prescribed when they are struggling with this particular disorder. It's not to say that psychotherapy is not helpful, and there's very specific moments within time for people who are struggling with this where that might be the most important thing. But drug interventions have kind of been considered a key element to helping people with this particular disorder. It's also true for the next disorder we're going to be talking about in the next couple slides. But before we get to that next disorder, which is actually a part of a different classification disorders, I do want to wrap up this last discussion that we're having on these classification disorders called mood disorders. I want you to recognize that we've gone through 4 different mood disorders now in total, and just like with the anxiety disorders, all of these mood disorders have a lot in common, but there's nuances to them that make them very unique and that really have pushed clinical psychologists over the years to give them distinct categories. And again, it's not because these things are necessarily kind of, I guess we could say, nominally different, right? We're not talking about them being completely different things that are hitting us in completely different ways. We're talking about the nuances, them being different enough for clinicians to want to have a term to kind of describe what's going on with these individuals so they can better understand statistics and treatment approaches that might best help these individuals. This idea of differences with kind of an underlying similarity is also going to be the same thing when we talk about that last classification of disorders that I've already alluded to a couple times now. And that last classification of disorders is called schizophrenia. What is schizophrenia? Well, schizophrenia is a very multifaceted mental health issue that unfortunately does not always manifest itself in similar ways from person to person. So one of the things that many people often do when talking about schizophrenia or clinical psych, when they're kind of getting to schizophrenia, is first start off by talking about what it's not, because unfortunately in our everyday community there are lots of misnomers about what schizophrenia is, and those misnomers have caused a lot of stigmatizing of individuals struggling with a variety of different symptoms related to schizophrenia, oftentimes in ways that are really detrimental to those people who do struggle with this particular disorder. So right off the bat, it's really important to note that all of those silly horror movies and other things that try to depict main characters who are really problematic as having schizophrenia is usually getting it wrong when they link schizophrenia to something called multiple personality disorder. It's also sometimes called dissociative identity disorder nowadays. Schizophrenia and multiple personalities are very different. Right? People who are struggling with schizophrenia, people who are given that diagnosis, are not indicated as thinking that they're multiple people or having multiple minds within their own head. Dissociative identity disorder is extremely rare. It's something that's almost never seen in today's society. There was a little uptick when there was kind of a change, a shift in society, and it really highlights how certain peculiar behaviors can be somewhat manifested through movies and the media, and just kind of what's happening with the time. But when we're talking about schizophrenia, this is completely distinct from multiple personality disorder. It's also not the same as sociopathic disorder. People who are struggling with schizophrenia have a lot of different things that they could potentially be struggling with, but they're taking joy in the pain and suffering of others is not a criteria for schizophrenia. It's also not a criteria that they are so distant that they tend to just kind of try to take advantage of others, like what we see in antisocial personality disorder. None of these things are there. There is occasionally some people who struggle with multiple disorders, and schizophrenia can be tied to some of these things, but that's rare. And it's really irresponsible to kind of try to tie those things to schizophrenia. And unfortunately, many, again, media outlets, movies, other sources of information do kind of unwittingly do that more often than not. But looking at what schizophrenia is then, as I mentioned, it can manifest itself in a lot of different ways, but for almost everybody struggling with some type of symptom combination in schizophrenia, What they're experiencing is usually a disconnect from reality. It can be through hallucinations, delusions, all these other things that we're going to talk about, but that disconnect tends to, once symptoms start to manifest themselves, grow, and there's a real need when somebody's struggling with schizophrenia to try to abate the detachment from reality as fast as possible. Just so you can understand how much this can really shift people, I always like to include this painting combination that an artist actually drew, as I believe it was he was developing symptoms of schizophrenia. He had reported seeing that his cat looked kind of different and wanted to kind of represent it in an image. So he drew the picture in the upper left hand corner when he was just starting to kind of experience symptoms of schizophrenia. As he progressed and as his mind started to kind of go in some very peculiar places, he kept drawing images of his cat and what he saw. And obviously, it gets a little extreme as you go to the lower right hand corner, but these are the types of things, maybe not this exact thing, but these are the types of things that people struggling with schizophrenia can sometimes experience when they are disconnecting from reality. What is out there then? What does make up schizophrenia? What causes these breaks from reality? Well, clinicians tend to lump a lot of things in this broad definition of schizophrenia. In general, it's a break from reality, but what types of breaks from reality are out there tend to get clumped into different symptom categories. And the four major symptom categories that are out there are what we call positive symptoms, negative symptoms, cognitive symptoms, and affective symptoms. And we'll go through all of these as we progress, but just so we kind of have a sense of where we're going to be going, know that positive symptoms and negative symptoms are not good things and bad things that these people have, but instead they're about behavioral patterns, thought patterns that these people are possessing that most people don't possess, or things that they're not displaying that people typically do possess. So positive symptoms are kind of doing stuff that wouldn't be done. Negative symptoms are not doing things that are typically done by people not diagnosed with this disorder. The last two symptom categories are kind of offshoots. Affective symptoms deal with mood, and oftentimes there are lots of mood issues, unfortunately, with schizophrenia, partially because of the other symptoms that are out there. And the cognitive symptoms don't really fit perfectly in the positive or the negative symptoms, so it's kind of its own category. And we're going to break those down a little bit more, but I want to start off with very prominent symptoms that are found in many people struggling with schizophrenia, and that's what we call the positive symptoms. Usually, the hallmarks to schizophrenia that most people think of, even though there are individuals diagnosed with schizophrenia that don't necessarily suffer with these things called hallucinations and delusions. Hallucinations are, just as the name kind of implies, these kind of experiences of things through our sensory organs that aren't actually there. And technically, hallucinations can come in a variety of different forms. There are some people that do experience taste hallucinations and smelling hallucinations or olfactory ones, but usually visual and auditory hallucinations are the most common, with auditory ones being even more common than the visual hallucinations. And for a long period of time, what researchers have tried to understand is where these things are coming from and why these individuals aren't able to differentiate them from their typical sensory experiences. There's actually been recent studies, recent is relative, studies done within the past couple decades that have really highlighted the challenges that many people struggling with these hallucinations actually are kind of encountering. In multiple brain scan studies, what they've shown is that when people are reporting hearing voices or sounds, the reason why they're reporting these things and are struggling to differentiate them from actual sounds and voices is because their brain activity patterns are almost identical when they're experiencing hallucinations than they are when they're not, when they're actually hearing something or seeing something. And this is really challenging then for most individuals to kind of be able to figure out what's real and what's not. And the brain is essentially incapable of distinguishing between these things, at least in our sensory spots, our what we call projection areas of the brain. And this is kind of a really tough thing to tackle on its own, and it's even more difficult when these hallucinations are paired with these things called delusions, which are kind of rigid, unfounded beliefs of variety of different things. And there are many different types of delusions that people can have. In fact, some clinicians like to kind of categorize the different delusions that people have, just so they can get a better sense of what's going on with a person, and how to maybe help them with the problems that they're struggling with. A common delusion that's out there is something called a delusion of persecution, where somebody comes to this belief that others, and others can be very vague. It could be groups of people, it could be a specific individual, it could be some questionable, unnamed thing, is conspiring somehow to get a person. And this can be about, spying on somebody. It could be about trying to kill somebody. It could be about trying to harm somebody. Get is a very vague term, because there are lots of different types of delusions of persecution that are out there. But essentially, almost everybody who struggles with these delusions of persecution tend to have a lot of fear, and tend to tie this to a whole bunch of different things in an unfounded way that causes them a lot of angst and problems. Another type of delusion that's somewhat common is these things called grandiose delusions, where they tend to believe, or people who struggle with this tend to believe, that they have some type of unusual importance. Usually this is involving some type of power or skill that they might possess. But there are some unusual ones. I had a colleague that was a grad student at Berkeley, who was helping a client out at the time, that swore that he had the ability to impregnate women just by flicking his fingers at them. Obviously, that's not a very common thing. I'm certainly not trying to highlight that as one that happens a lot, but these are the types of kind of unusual delusions that people can sometimes have. Some other ones that pop up are these things called reference, or delusions of reference, where people start to kind of find connections between things that aren't really there. And the classic example is people reading newspapers or books, and finding hidden messages within them that seem to be right there for them. And then there's these other things called bizarre delusions, where the kind of combination of ideas that they come up with don't really fit into any category really well, so they just kind of get lumped into this last category. Another colleague of mine actually talked about a client that, for some inexplicable reason, came to the conclusion that I think it was she was missing organs. And she was convinced that her organs that were missing were going to be a problem in the future, and why she was missing the organs, what the heck was going on around it, was really unclear. But she was convinced that this was a big problem that needed to be addressed. And these, again, all fit into the category of what we call positive symptoms of schizophrenia. Not everybody possesses them. There's usually a combination of things that can sometimes pop up in individuals. But if they're there, then this is a big indicator that somebody's probably capable of being diagnosed with schizophrenia. Now, the negative symptoms of schizophrenia are not defined as such simply because they're things that aren't desirable for individuals. I just need to reiterate that again. But what we're looking at with these negative symptoms are kind of behaviors and kind of thought processes that these individuals are not necessarily displaying, that are typical in the kind of repertoire of most individuals. One particularly common one that many people with schizophrenia struggle with is this thing called anhedonia. Now, anhedonia is a symptom itself that can actually be manifested in a number of different disorders, but if in combination with other symptoms anhedonia appears, it can be really problematic for these individuals. Anhedonia entails kind of sort of emotional withdrawal from most situations. And what it also tends to lead to is another very common negative symptom called blunted affect, where not only are you not feeling the typical range of emotions if you're struggling with anhedonia, but you're also not expressing a typical range of emotions. Usually it's focused primarily on the face when people look at blunted affect. That's usually kind of what people highlight when talking about this particular symptom. But blunted affect goes beyond just that. It also deals with the kind of communication processes that these individuals engage in, the social norms that they follow. In essence, we rely a lot on our emotional world on a day-to-day basis for communication processes and just to kind of understand what's going on. And for people struggling with these negative symptoms of schizophrenia, those cues, that information that's relied on, isn't there. And this can cause lots of angst and lots of problems for these people. So oftentimes when they do start to struggle with social interactions, they tend to kind of self-isolate. And this social withdrawal can have a huge impact on their ability to function and really prosper. And it's also oftentimes paired, especially when those positive symptoms that we've talked about previously are present, with poor self-care. This can mean kind of isolation to the point where these individuals aren't taking care of their health and are potentially doing things that are detrimental to themselves because they're really not capable of kind of having the insight and recognizing what's going on and how they're doing damage to themselves and maybe even others that they're kind of around. These negative symptoms, I need to highlight again, are not necessarily universal for all people diagnosed with schizophrenia, but they are somewhat common. And if somebody's struggling with these in combination with some other symptoms, that's when you start talking about a diagnosis of schizophrenia. As I mentioned earlier, there are some other categories of symptoms that are out there beyond just the positive and negative ones. Positive's not good, it just means that there's those presence of things that aren't in most typical individuals' behaviors and thought patterns. But okay, going back to the cognitive symptoms, what we see is sometimes a lot of symptoms that relate to cognitive functioning, memory, attention, language skills, really don't quite qualify perfectly as positive or negative symptoms. So they kind of get lumped into this other category so clinicians can talk about and recognize and kind of diagnose these issues that are somewhat common with schizophrenia. One of the kind of more telling signs of schizophrenia outside of the hallucinations and delusions are cognitive symptoms that relate to language. Oftentimes, people who are struggling with schizophrenia, when you kind of converse with them, show very clear indicators that their minds and the thought processes that they have are no longer on the traditional trajectory. Usually, when you talk with somebody who's struggling with schizophrenia, their thoughts are kind of jumping around. The associations between topics are loosely related at best, and it's really challenging to kind of understand exactly what they're getting at most of the time. It's very different from two friends that are super excited about things and are just jumping all over the place from topic to topic. What we're talking about here is people who really can't have a typical stream of logic coming out. It's something that's constantly getting abutted, something that's constantly getting interrupted, something that really just is jumping all over the place. Now, what's really problematic with these cognitive symptoms is that oftentimes there are nuggets of indicators that kind of suggest what a person's trying to roughly get at and some of the thoughts that are going on in their mind. And that's sort of a logical thing, right? These people aren't trying to just spew out nonsense. There's an attempt to communicate and an attempt to make sense, but because of the disorganized chaos going on in the minds of many of these individuals in terms of kind of what they're paying attention to, what memories they're grabbing, how they're associating things, what comes out is extremely disjointed. And the kind of almost intrigue in trying to decode what people are saying sometimes looks past the point that these people who are communicating in weird ways are not speaking some special type of language, not doing something that you have to just decode, but they're really manifesting symptoms of a brain and a mind that's becoming extremely disorganized. And there's a big need to try to help them find ways to get things realigned or at least minimize the amount of disorganization that's there. It's also true of affective symptoms that aren't, again, positive or negative, but are very commonly seen in people struggling with schizophrenia. Often these affective symptoms are really a byproduct of a lot of the other symptoms that we've talked about. So if delusions and hallucinations are really strong, then severe depression can very commonly occur, and so can big anxiety issues that even get past the threshold of maybe qualifying as an anxiety disorder. And this is something that's worth mentioning, that schizophrenia is comorbid with a lot of other different disorders. It's really tough to tease apart which one is leading the charge. Are these symptoms that people are struggling with just a byproduct of the other symptoms of schizophrenia, or are they kind of another disorder that these people are struggling with? And unfortunately, it's really tough to separate it out, but what most clinicians have argued is it doesn't really matter which is leading which. If you're trying to help somebody with schizophrenia, you want to address all the different things that they're struggling with, and these things are unfortunately very common for people who do struggle with this particular disorder. We're looking to try to figure out what clinicians then are using to define schizophrenia. Hopefully now you understand there's a lot of different types of symptoms that are out there. And that's why in schizophrenia, what most clinicians will do is kind of categorize the type of schizophrenia that people have. Your book goes into lots of different types of schizophrenia that are out there. For purposes of time, we don't have the ability to go into all those different types of schizophrenia that are out there. I also don't love doing it because those types do tend to change with each edition of the DSM. But just know that in the DSM, schizophrenia is kind of an umbrella classification of disorders that fits in a bunch of different groupings. And when people are diagnosed with it, usually they do have a combination of different symptoms that we've talked about. And that's what determines what type of, schizophrenia they have. In terms of things that could potentially get them past the threshold without having multiple symptoms, even though that's kind of rare, if hallucinations and delusions are really strong in an individual, there isn't a need for at least two groupings of symptoms to kind of qualify somebody as possessing schizophrenia. But again, all this is just kind of random semantics. When we're talking about schizophrenia, we're talking about people who have a clear mental break from reality. And it doesn't really matter what that mental break from reality is. There's a need to diagnose, and there's a need to try to help these individuals with these specific problems. Looking for one minor good thing from this particular disorder, which can be really debilitating, it is really uncommon. We've seen really steady numbers over the last couple decades suggesting that only about 1 to 2% of the population struggles with symptoms related to schizophrenia at some point in their life. But that's a big number if you look at it in the grand scale of things. That means we're talking about, in the United States population, around 3 million people that are diagnosed with this at some point in their life. That's a very large number if you think about it in that particular scale. It's about the population of the Bay Area, if I recall correctly. It's not something to kind of scoff at if you think about it in that particular way, even though maybe only 1 in 80 or 1 in 90 individuals might be diagnosed with this at some point in their life. And we're looking at kind of who's more inclined to be diagnosed with it. Gender doesn't seem to be something that matters that much. There is some research, we're going to talk about this a little bit later, about life experiences that could potentially play a role in this. But what we tend to see, as I'm going to talk about in the next slide, is that this one's more about genes than anything else. And it's unfortunately something that you seem to have a proclivity to develop if you've got the right combination, but it doesn't emerge until much later for individuals in comparison to a lot of the other disorders that we've talked about. And in fact, for women, it doesn't usually manifest itself until the early 20s. And this is something that's kind of surprising to a lot of individuals when they hear about this. And most of the disorders that we've talked about so far tend to manifest themselves, at least in some form, at younger ages. But many individuals can go on in their lives not having any symptoms, any issues that could potentially be linked to schizophrenia, and then in their mid-teens to early 20s, they start to display a few random symptoms, and those symptoms start to ramp up, and they start to carry over into other things, and things can very quickly spiral out of control. And that's kind of jarring when you think about that time frame and the kind of way that this particular disorder comes on. And because of that, there's been a big push within our psychological community to try to figure out what's the source of schizophrenia, what's kind of the trigger for individuals, so we can maybe try to help people stave off developing these symptoms if there is indeed something that can be averted between birth and the age of around 16, 17, 18, when most people start to manifest symptoms. Now, there has been, as I mentioned earlier, a lot of studies that have shown that this does seem to be a highly heritable thing. Numerous sibling studies have shown that schizophrenia is very inherited. In fact, if we look at this slide here from about a decade ago, actually 15 years ago, I need to update this. This numbers still hold true, but if you look at this slide here, you can see that the heritability rate of schizophrenia is about 50%. Essentially, if you've got an identical twin that is diagnosed with schizophrenia, you have a 50-50 chance of also being diagnosed with it at some point in your life. If you've got two parents that have been diagnosed with schizophrenia, you again have a 50-50 chance of being diagnosed with schizophrenia at some point in your life. As you move down the genetic overlap chain, the rates drop. But essentially what this suggests is that genes really, really matter for this particular disorder. But it's really important to note that since we've been sequencing genes, since we've been looking at heritability, that 50% cap seems to be consistently where we're at. We haven't found specific gene markers that suggest this is the gene tied to schizophrenia. We have not been able to necessarily up or kind of lower the inheritance link over the last couple decades when looking at schizophrenia. And what that screams to many researchers is that biology definitely does seem to matter, but there has to be something else that's the source to it. And what lots of people have looked at when trying to figure out when these symptoms are emerging is how the brain itself is actually changing. And what most research has shown is that when people get into their teens and later years, the brain itself does start to shift in terms of the structures and the cells that are a part of this particular system. And whether or not these changes in the brain are happening as a result of schizophrenia or whether or not they're kind of causing symptoms of schizophrenia is debatable. If you look when people get into their adulthood at two brains of an individual diagnosed with schizophrenia and one not diagnosed with schizophrenia, what you can see is there are tangible differences between the brains of those individuals. It's tough to catch right off the bat, and when people start manifesting symptoms, you really can't see it very well unless you look really down at the cellular level, and then it's kind of shaky at best. But this type of stuff really does highlight how once schizophrenic symptoms hit, it's not just the symptoms that are popping up, it's changes in the brain that are occurring. And when we recognized that this was the case, one of the things we started to really push was what was the source of this change in the brain? What was the source of this kind of alteration in the behavior of these individuals? One of the first theories to really be pushed and widely accepted by the clinical community was something called the neurodevelopmental hypothesis of schizophrenia. It suggested that maybe some early moment in life during infancy or childhood related to kind of exposures to viruses or some type of traumatic experience was a catalyst for the brain to eventually, later on in life, go down the path of developing symptoms of schizophrenia. There's been a lot of pushback on the original neurodevelopmental hypothesis that suggested it was just one thing that could potentially cause it, primarily because we haven't been able to find that silver bullet that seems to be the predictor for everybody developing symptoms of schizophrenia. So now many people argue that it's probably actually a multitude of things that have to come together and kind of push people in the direction of developing symptoms of schizophrenia. And moreover, it seems to be that the biology of a person can vary from person to person who's struggling with symptoms of schizophrenia, and there's kind of an interaction, a feedback loop between that biology and the environment that seems to be the source of it. But even if we can find those things, we still haven't been able to tangle apart what causes that first start in the shift of the brain once symptoms start to emerge. And also, we can't quite yet figure out how drug interventions or early types of interventions, even before people start being symptomatic, could potentially shift what happens to the individual as well. So much like the variety of different causes to schizophrenia, there's also a variety of different types of treatments that have been incorporated into trying to help people with a variety of different symptoms for schizophrenia. Historically, schizophrenia, since it is kind of a lifelong thing once people start displaying symptoms of it, it has been tied to treatments in hospitals. In the past, many individuals who started manifesting symptoms of schizophrenia would essentially be taken to a hospital and left there pretty much for life with the expectation that all you could do is at best just kind of tried to moderate the symptoms that people were struggling with, accepting that things were going to continue to spiral worse and worse out of control throughout the lifetime of these individuals. For a few cases nowadays, this is still something that can pop up. In fact, there are some individuals who can be hospitalized when they're having a specific mental break and then kind of coming back to a place where they're more functional. But hospitalization with schizophrenia is something that's not really used that often today. If we're looking at other things that have kind of taken its place, one of the things that is really kind of picked up in steam over the last couple decades is different types of antipsychotic drugs that can really help individuals with a variety of different symptoms. Mood stabilizers are also sometimes used to help people with these problems. But what we've seen historically with these drugs is that they do have, fortunately, a sordid history. When some of the early antipsychotic drugs were developed, there was an amazing kind of immediate effect with many of these drugs on a variety of different symptoms that people were struggling with. But what we did not know when people started having these drugs administered on a regular basis was that there was also some long-term side effects that started to emerge. One particular thing which is really problematic is this thing called tardive dyskinesia, where people start having these kind of weird tics and repetitive behaviors that kind of come up as a result of some of the drugs that they're taking. Dystonia, where the body starts to kind of set in places and writhe, also is something that can potentially happen. Seizures happen for many individuals. Another kind of day-to-day side effects like dry mouth and other things started to kind of be reported by large numbers of individuals who were taking some of the early antipsychotic drugs. And what made this even more problematic was for many people, once they stopped taking the drugs, their symptoms came back, but the side effects remained. And this really detracted from a lot of attempts to try to treat in the early days when treatments were kind of made available, people with schizophrenia with these different medications. So it actually took lots of different tinkerings with different medications for people to start kind of going back down that path for treating schizophrenia. And nowadays, it's something that's used a little bit more commonly, but it's something that's used in a slightly more directed way, where there's a multitude of different drug combinations that have been developed, and all of them are trying to tackle different symptoms while also monitoring whether or not there's any side effects that could potentially emerge from the drug combinations that people are taking. And with those changes, many people have kind of seen a light at the end of the tunnel, but recognize that there's still a persistent issue with schizophrenia, and that's the fact that this is, since it is a lifetime disorder, something that constantly needs to be vigilantly monitored. Many people, when they're not experiencing symptoms or when the drugs are working well, sometimes don't identify the need to continue taking the medicine, especially when potential side effects could start to emerge. There's a big distaste in kind of taking something that could have some really detrimental impacts on the health of an individual. So finding the right drug combination, finding drugs that do work over a long period of time is the goal. But fortunately, that there are some drugs that are out there that are proven to be very effective. And we're going to talk a little bit more about that drug treatment a little bit later on the next slide. But I do also want to mention that there are some psychological approaches that have proven to be somewhat effective as well, especially for milder symptoms of schizophrenia. CBT, cognitive behavioral therapy, is something that's very commonly used. And when it comes to the affective symptoms, there's a variety of different techniques that have proven to really help people with the anxiety, the depression, the other issues that come along with some of the other positive and negative symptoms of schizophrenia that are out there. So it's not just drugs that are usually used to treat people or help people. There's lots of different types of interventions that can help with a variety of different things that people are struggling with when they do develop symptoms that kind of fit them under the umbrella of being diagnosed with schizophrenia. We're talking about some other issues with drugs. I've already alluded to them sort of earlier, but I think it's important to kind of go back and visit them. And that's the fact that this particular topic of treating individuals with drugs has become uh, a kind of an ever-moving target because not only is there lots of complexity to schizophrenia, but the treatment of individuals is very complex. There's big differences from individual to individual in terms of when their symptoms manifest themselves, how quickly they come on, and how well drugs work. Most drugs work almost instantly for a large percentage of the population when they're taken. In fact, here you can see that within the first month, most people taking any drug, even a placebo, tend to report that the effects of the drugs are pretty instantaneous. That some of the delusions, cognitive symptoms, hallucinations, whatever they're struggling with, usually go away. Uh, and even within a matter of months, these drugs, even if it's a placebo, can have kind of a lingering effect. But about a year after these drugs are taken, you're getting to a point where only most drugs are having about a 50% efficacy rate. And this usually screams that whoever's seeing this waning effect needs to actually get on a new drug. And in fact, you want people to transition to a new drug even sooner than that if you start seeing these effects start to wane after just a couple months. Finding the right drug combination, one that's not going to have side effects and one that's not going to see this waning effect, is a big issue with schizophrenia. Another thing that's really important here is that you have to remember kind of what these drugs are doing to the brain and what these drugs are doing to the person's body. What we've been looking at in the last couple years is what these drugs are doing to kind of stave off the degeneration of the brain that we talked about earlier. Some do seem to be having some impact, others not so much. And when looking at these issues, what many clinicians have argued is that even though we have a name for this, that kind of encapsulates lots of people struggling with these problems, really these long-term effects needed to be handled on a case-by-case basis. If we do that, there is some hope that many people can see the benefits of the different treatment plans that are being explored with this particular disorder. And I know this is not necessarily the best place to close out the class, but believe it or not, we have officially reached the finish line. So this is going to mark the end of our lectures. Hopefully this discussion of schizophrenia and all the mood disorders and the previous discussions we've had has been illuminating, and it's given you a chance to be a little bit more sensitive and aware of some of the struggles that people have and some of the stigma and kind of nuanced issues that go along with mental health. And if you've got that down and you're able to review some of the other stuff, I'm hoping you're going to be well prepared for that third exam that we have coming up. I do want to reiterate that you want to make sure that you're also watching the section videos and that you are not only studying for this third exam, but if you're planning on taking the optional final, which will be offered online just like the third exam here, you will want to kind of study everything from beginning to end. So you're up to date on everything from the class because that optional final is cumulative. The third exam is not, obviously. So that's going to mark the end of everything for the class. Wish you all the best of luck in your studies. If you're working on your paper still, good luck with that. And hopefully I will see some of you on campus at some point in your later college careers. Take care all. Bye.